Welcome, future colleagues. Today we will explore the elegant architecture of the human spine. We will transition from its bone structure to clinical insights like disc herniation and spinal stenosis. This is essential for your clinical practices. This lecture is structured into three main chapters. We will first cover the basic structure and curvatures of the spine, then look at regional variations, and finally compare two common clinical pathologies. Let us begin with our first chapter, covering the structural basics and natural curvatures. We will examine how the 33 vertebrae arrange themselves to provide support and mobility. Our spinal curves are dynamic adaptations. In utero, we have a continuous C-shaped primary kyphosis. As we develop motor skills like head control and walking, we develop our cervical and lumbar secondary lordotic curves. Now let us examine common spinal deformities. Kyphosis presents as an exaggerated thoracic curve, lordosis manifests as an excessive inward curve of the lower back, and scoliosis is a lateral shift to the side. Most vertebrae share a common blueprint. The solid anterior body is optimized for weight bearing, while the posterior arch creates a protective canal for the delicate spinal cord traveling within. Moving on to our second chapter, we will discuss how vertebrae adapt as we move down the spine. This will explain the specialized mechanics of cervical, thoracic, and lumbar regions. The cervical region, spanning C1 to C7, supports the head. C1, the atlas, cradles the skull, while C2, the axis, provides the pivot point. This combination allows for a wide range of head movements. The thoracic vertebrae, T1 to T12, secure the rib cage, offering stability at the expense of movement. In contrast, the large lumbar vertebrae, L1 to L5, are built to bear body weight and allow flexion and extension. We now enter our final chapter on clinical pathologies. We will contrast disc herniation and spinal stenosis, focusing on how different mechanical issues lead to distinct patient symptoms. An intervertebral disc acts as a shock absorber. When a herniation occurs, the soft inner core protrudes through the outer cartilage ring, which can compress nearby spinal nerves and cause pain. Spinal stenosis is the narrowing of the spinal canal or exit passages. This is often an age-related change that puts pressure on nerves. Standing or walking can exacerbate symptoms, which are often relieved by leaning forward. Let us summarize how to differentiate these two conditions. Disc herniation typically affects younger patients with symptoms worsening on flexion. Spinal stenosis affects older adults with symptoms worsening on extension. Thank you for your active participation today. Keep these structural and mechanical principles in mind during your next clinical rotation. I will see you in our next practical session.